Welcome to Board Pearls. This is episode 1 of 6 of the GI and Pregnancy chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover pregnancy physiology and nausea and hyperemesis gravidarum, the pregnancy-shifted normal labs, the ultrasound and non-contrast MRI imaging menu, and hyperemesis management with thiamine before any glucose to prevent Wernicke encephalopathy. The whole chapter rests on one principle. Pregnancy itself shifts a predictable set of labs and physiologic findings, and any deviation that pregnancy itself does not cause is, by definition, pathologic. That is the lens. You cannot interpret a pregnant patient's labs against the non-pregnant reference range. You have to know which numbers move and which do not, because the ones that do not move are the ones that tell you something is wrong. Start with volume. Plasma and blood volume rise by roughly half over the course of pregnancy. Cardiac output rises, and peripheral resistance falls. Total hepatic blood flow stays about the same, but the fraction of cardiac output reaching the liver falls because the denominator got bigger and flow redistributes to the placenta and the uterus. That single change explains a lot of what you see. Telangiectasias and palmar erythema show up in about 60% of normal pregnant women from estrogen-driven peripheral vasodilation, so those skin findings do not mean chronic liver disease in a pregnant patient. The gravid uterus in the third trimester can compress the inferior vena cava enough to produce transient esophageal varices in women with structurally normal livers, purely from mechanical impedance of venous return raising portal pressure. The CBC follows the volume change. Hemoglobin falls by dilution. The anemia of pregnancy is largely dilutional, not synthetic. The white count drifts up into the 12 to 15,000 range as a physiologic response, and peripartum it can run as high as 25,000 and still be normal. So leukocytosis alone does not establish infection in a pregnant patient. Creatinine drops because glomerular filtration goes up. A pregnancy creatinine is usually below 0.8 milligrams per deciliter. That means a creatinine of 1.0, which looks reassuring on any other ward, is high for this patient and warrants a workup rather than a shrug. The liver tests follow the same logic, and there are two interpretation rules that carry most of the weight. The first is that AST and ALT do not rise in normal pregnancy. There is no physiologic mechanism that lifts them, so any elevation is pathologic, and the workup starts. The second is that alkaline phosphatase rises progressively across the second and third trimesters, often to twice baseline by term, but the source is placental isoenzyme, not liver. The discriminator is GGT. Placental ALP brings GGT along for almost nothing, because estrogen actually impairs hepatic GGT release, so an isolated ALP rise with a normal GGT is expected. ALP plus GGT together is what points to a hepatic cholestatic process. That distinction sits behind one of the most common stems in this section. Picture an asymptomatic third trimester patient with an ALP 2 to 3 times the upper limit of normal. Transaminases, bilirubin, and bile acids are all normal, and so is the GGT. That patient does not need imaging, does not need bile acids redrawn fasting, and does not need an MRCP. She needs reassurance because the pattern is placental. Bilirubin stays normal or only slightly elevated because of decreased canalicular secretion under estrogen influence. Albumin falls dilutionally, not because the liver has stopped making it, so a low albumin in pregnancy does not carry the prognostic weight it does in cirrhosis. Cholesterol and triglycerides rise because estrogen drives hepatic synthesis to support fetal lipid demand. Coagulation factors go up because hepatic synthesis is upregulated, and pregnancy itself is a prothrombotic state. Alpha fetoprotein rises progressively from fetal synthesis crossing the placenta. Drug metabolism shifts under estrogen and progesterone effects on hepatic cytochrome P450, which is why tacrolimus and cyclosporine and anti-epileptic trough levels need closer monitoring in pregnant patients. Then the biochemistry. Pregnancy produces a lithogenic bile profile through 3 concurrent mechanisms. Estrogen drives more cholesterol into bile. Bile salt secretion falls. Progesterone impairs gallbladder contractility and increases gallbladder volume so bile stagnates. Roughly 10% of pregnant women develop gallstones or biliary sludge, and the lithogenic state normalizes 1 to 2 months postpartum. The modern post-vaccine incidence of abnormal liver enzymes in pregnancy runs 3 to 5%. The 3 dominant causes are gallstone-related disease at about 25%, preeclampsia and HELP at about 25%, and intrahepatic cholestasis of pregnancy at about an eighth. Viral hepatitis sits below those because of HPV vaccination and HCV screening. Now imaging, which follows the same fetal protective logic. Ultrasound without Doppler is the first-line modality in all 3 trimesters. It uses no ionizing radiation, no contrast, and it adequately images the liver, gallbladder, biliary tree, and pancreas. Doppler is acceptable when needed, but exposure time is minimized because acoustic energy can theoretically cause tissue heating. MRI without gadolinium is acceptable in all trimesters and is preferred over CT when cross-sectional imaging is needed. Gadolinium is avoided because it crosses the placenta and accumulates in the fetal urinary tract and the amniotic fluid. The concern is that free gadolinium can dissociate from its chelate during prolonged residence in the fetal compartment, raising a theoretical neurotoxicity risk. CT is performed only when the diagnostic benefit clearly exceeds the radiation risk, with lead shielding to the pelvis and lower abdomen. The cumulative fetal dose stays generally below 50 mg, and a single CT of the abdomen and pelvis delivers approximately 25 mg to the fetus. That is well below the threshold, but it is also half of it, so a second study is not free. The trimester principle for radiation risk runs in 3 windows. Anatomic teratogenicity is highest during organogenesis under 8 weeks. Intellectual deficit risk dominates from 8 to 25 weeks during cortical neurogenesis. Risk falls off sharply beyond 25 weeks. Procedures inherit the same logic. Cholecystectomy and ERCP are timed to the 2nd trimester whenever feasible, because organogenesis is complete and the gravid uterus has not yet crowded the operative field. Laparoscopic cholecystectomy is preferred over open. ERCP is done with limited fluoroscopy and fetal lead shielding. Flexible sigmoidoscopy without sedation is safe at any time. Colonoscopy with sedation and fetal monitoring is reserved for indications that cannot wait until postpartum, again, ideally in the 2nd trimester. Elastography is not validated in pregnancy because pregnancy-related parenchymal changes affect liver stiffness and produce false positive fibrosis readings. That is the physiologic baseline. Now to the symptoms that ride on top of it, starting with nausea. Nausea and vomiting of pregnancy affects 70 to 80% of pregnancies and typically resolves by the 20th week of gestation. Hyperemesis gravidarum is the severe end of the same spectrum. It is defined by persistent vomiting beyond a week, weight loss above 5% of pre-pregnancy weight, dehydration with ketonuria, and electrolyte abnormalities. Hyperemesis affects somewhere between 0.3 and 2% of pregnancies. The risk factors are higher pre-pregnancy body weight, twin pregnancy, and nulliparity. Recurrence in subsequent pregnancies is common, on the order of 64%. The hyperemesis liver test pattern is itself testable because it has to be distinguished from the cholestatic and hepatocellular liver diseases of pregnancy. Up to half of hyperemesis cases and about 2/3 of hospitalized hyperemesis patients have abnormal liver tests. Transaminases are typically below 1,000 units per liter, with ALT often higher than AST. Alkaline phosphatase rises modestly, up to twice baseline. Bilirubin can climb to about 4 mg per deciliter and is mostly unconjugated. The defining feature is that all of those abnormalities resolve with hydration and the resolution of vomiting. That is what tells you the liver injury was dehydration and starvation, not primary hepatic disease. Intrahepatic cholestasis of pregnancy and viral hepatitis do not resolve with fluids because their transaminase elevation reflects ongoing hepatic injury rather than the metabolic consequences of intractable vomiting. The treatment sequence for nausea and hyperemesis follows a mechanistic logic in which each step targets a different antiemetic pathway. First-line therapy is pyridoxine, 10 to 25 mg orally 3 to 4 times daily, often combined with doxylamine 12.5 mg 3 to 4 times daily or at bedtime. The fixed-dose combination of pyridoxine 10 mg plus doxylamine 10 mg per tablet is sold as diclegis or diclectin and is dosed up to 4 tablets daily. The reason this is first-line is mechanism plus safety. Pyridoxine is a coenzyme for amino acid metabolism and central neurotransmitter synthesis, and it modulates nausea pathways through GABA and serotonin precursors. It has a long safety record and minimal placental transfer. Doxylamine is a first-generation H1 antihistamine that dampens vestibular and chemoreceptor trigger zone input. The two together hit two pathways with minimal fetal exposure. Second line adds either a 5-HT3 antagonist or a dopamine antagonist. Ondansetron 4 to 8 milligrams every 8 hours blocks 5-HT3 receptors in the chemoreceptor trigger zone and is highly effective. There was an FDA signal of first trimester cardiac defects more than a decade ago that raised concern. Subsequent meta-analyses have been broadly reassuring, so ondansetron is now widely used in pregnancy with informed consent. A small residual cleft palate signal in the first trimester is mentioned during counseling. Metoclopramide blocks dopamine D2 receptors in the chemoreceptor trigger zone and adds a prokinetic effect on gastric emptying. Prochlorperazine and promethazine fit on the same line. The single most testable rule in this section is the thiamine before glucose rule, and it is testable because the mechanism is precise and the failure mode is catastrophic. Any pregnant patient with prolonged vomiting who needs intravenous fluids gets thiamine 100 milligrams before or with any glucose-containing fluid. The reason is direct. Thiamine is an essential cofactor for transketolase and pyruvate dehydrogenase. In a thiamine-depleted patient, and a few weeks of vomiting are enough to deplete her, glucose loading drives glycolysis, but pyruvate cannot enter the TCA cycle because pyruvate dehydrogenase has no cofactor. ATP-dependent maintenance in mammillary body and thalamic neurons fails. Acute Wernicke encephalopathy can be precipitated by the glucose alone. The classic triad of confusion, ophthalmoplegia, and ataxia appears within hours. 80% of untreated Wernicke cases progress to Korsakoff amnestic syndrome, which is irreversible. So the STEM you will see is a patient on day 1 of admission for hyperemesis. She gets started on D5 normal saline at 150 per hour. 6 hours later, she has horizontal nystagmus, ophthalmoplegia, and ataxia. The answer is thiamine 100 milligrams intravenously, and the deeper answer is that thiamine should have been given before the dextrose ever ran. Refractory hyperemesis escalates to systemic corticosteroids and, as a last resort, total parenteral nutrition. Methylprednisolone is typical, at 16 milligrams every 8 hours for 2 to 3 days followed by a taper. Steroids are held until after 10 weeks of gestation because of a possible first trimester cleft palate signal. Both steroids and TPN are reserved for clear failure of first and second line therapy. A word on the differential that the boards will try to confuse with hyperemesis. Take a patient at 28 weeks with nausea, vomiting, and weight loss. She also has new intense pruritus on the palms and soles, worse at night. Her bile acids are 86 micromole per liter, and her ultrasound is clean. That is not hyperemesis with secondary transaminitis. The palmoplantar's pruritus and the elevated bile acids localize the diagnosis to intrahepatic cholestasis of pregnancy. Hyperemesis can elevate transaminases, but it does not elevate bile acids, and it does not produce pruritus on the palms and soles. ICP is the entity that opens the liver episodes, so set that recognition aside and keep going. So pull the physiology and hyperemesis together. The physiologic baseline shifts in predictable ways. Volume expansion drops the hemoglobin and the creatinine, and the white count drifts up. Placental ALP rises with a normal GGT. AST, ALT, and bilirubin stay normal because nothing in pregnancy physiology drives them, so any elevation is pathologic. Imaging follows fetal protection. Ultrasound first, MRI without gadolinium second, CT only when the benefit clearly exceeds the dose. And the symptoms layer on top. Hyperemesis runs the antiemetic sequence from pyridoxine plus doxylamine through ondansetron and metoclopramide to steroids, with the absolute rule that thiamine goes in before any glucose, because glucose loading in a thiamine-depleted patient precipitates Wernicke, and Wernicke runs to Korsakoff. The next episode takes the other upper GI symptom that rides on the same physiology, GERD and peptic ulcer disease in pregnancy, run as a safety-tiered pharmacologic sequence from calcium carbonate and sucralfate through famotidine to the PPIs, with misoprostol off the table because it contracts the uterus. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 6 of Chapter 35, and I'll see you in the next one.